rTAPP repair of a traumatic flank lumbar hernia. Our patient is a 32-year-old male who was in a motor vehicle collision approximately 2 years ago and developed progressively enlarging right flank bulge. Patient was limited in his ADLs because he was scared to work out. Consequently, he gained a little bit of weight in that period of time. CT scan of the abdomen pelvis shows our operative plan: pre-peritoneal dissection from underneath the right rectus, across the abdominal wall, reduction of the hernia sac along with a sliding colon component, while bringing back the 3 layers of the abdominal wall back to the iliac crest. After prehabilitation, patient lost weight to increase his level of fitness, was no longer scared of working out. This was the initial laparoscopic appearance of the hernia defect. Patient had some ascending colon sliding into that hernia, so I knew reduction of that colonic segment would be accomplished with preperitoneal dissection, reduction of hernia sac. When I'm working with residents, I try to give them mini goals to be efficient. Residents tend to be ADHD. They're kind of all over the place unless you direct them to exactly what you want to do. So the first step after peritoneal incision was dissection to the top of sac. You can see I like to dissect on one side, dissect on the other side, create these apices, and then go right down the apex. Typical. I always tell a patient, well, the next step would be a dissection of the area cephalad to the hernia defect. I always tell them I'd like to envision, if my fingers were in there, what kind of movements my fingers would be doing. This is linea semilinaris, the junction of the between muscular TA and aponeurotic TA. But essentially, copy what my fingers would doing with the end effectors of the robotic instruments. So you can see the relationship of the top of the hernia sac to the retroperitoneal fat. So we dissected top of sac, cephalad to the sac, and now we're going to dissect the area caudal to the hernia. Again, preperitoneal dissection. This is essentially is going to be into space of Bogros, zone 1 dissection, the MPO, and I like to stay true preperitoneal. I say if you follow the peritoneum, the worst thing that can happen is you get a hole in the peritoneum. You don't want to go too deep in space of Bogros because you can run into the nerves at the area of the triangle of pain. So here I'm preperitoneal into space of Bogros, lateral to cord structures, lateral to the inferior epigastric vessels. Now I'm going into zone 3 of the myopectineal orifice. Dissected a little bit of zone 2 into space of Retzius, isolating where the inferior epigastrics are and the spermatic cord going through the deep internal ring. This would represent the caudal aspect of my preperitoneal dissection. So you have the space of Bogros, you have the caudal margin of the hernia sac and its relationship to the transversus abdominis muscle. So now we have our volcano sign. We know exactly what should stay, what should go, what should reduce, while keeping in mind there is colon in there. So you have to be judicious and meticulous about the burn that you do to decrease the risk of thermal burn injury to the sliding bladder component. Always taking a look under the flap to see where I'm at relative to where the colon is at. You can see I'm getting towards the base of the defect. You can see my peritoneal flap appearing thicker. That's the colon on the other side. Again, that's part of the hernia sac, thereby calling it a sliding component. I'm going to exploit the use of table motion to give me more right side up to be able to hopefully allow gravity to assist in my dissection. So this is the last part that needs to go down. Again, clearly peritoneum entering into the caudal portion of the sac, deeply associated with the iliac crest, which is going to be obviously an important landmark because that's what I want to suture the lateral abdominal wall muscles back to. You want to stay, again, true preperitoneal here if possible to risk or decrease the risk of injury to nerve structures. It's the iliac wing, quadratus lumborum. My goal is to get to the medial border of psoas. I know the quadratus is just lateral to that, so continued retroperitoneal dissection. I think it's easiest to find the psoas in the lower abdomen. But here we are just completing a reduction of all of the hernia content. This is a little bit of preperitoneal fat that is herniating in between layers of the abdominal wall. So now I'm pretty happy with that reduction of the sac. Now it's all about getting to psoas muscle. And like I was saying before, I think it's easiest to find the psoas in the lower abdomen. Familiar with that area, doing inguinal hernia repair. There's the psoas. There's the ureter, medial border psoas. And you can see I'm just dissecting carefully at top of psoas muscle, trying to leave transversalis fascia on top of that. You can see cord structures there, the vessels, gonadal vessels. Here's the iliac vessel. So I'm pretty happy that I'm down to the medial border of psoas there. Just making sure my cephalad retroperitoneal overlap is adequate as well. So here's the defect. Here's the preperitoneal dissection. I don't think we encountered any holes in the flap. I'm utilizing number 1 barb suture, utilizing the head-end menu to be able to decrease pneumoperitoneum. You can see I'm trying to get the lateral abdominal wall muscles, that being TA and IO here, and probably a little bit of external oblique, and suturing back to the periosteum of the iliac wing. You can see this is coming together without too much tension. I start on going top down, then I'm going bottoms up. We meet in the middle. The defect is closed. The muscles are back, associating with the iliac crest, back to where they should be, allowing these muscles to hopefully fire appropriately and maximally in the postoperative period. I utilize a heavyweight mesh here that's going to contour over psoas. I utilize PDS cardinal suture to ensure that the mesh looks flat. Couple sutures in the retroperitoneum on top of psoas. Utilize table motion to get the retroperitoneal organs back on top of the inferior border of my flap to reduce the risk of clamshelling. And then we utilized 3-0 barb suture to close the peritoneal flap. Patient did well, was discharged on post-op day 1. I have seen him in 3-month follow-up, and he continues to thrive, lose weight, and working out. Thank you. Bye.